Thank you. And thank you for the invitation and the introduction. So when we talk about suturing-based devices in the US, a lot of people in the audience may remember the different companies that had suturing-based devices that are no longer in shape. And a lot of the companies are working on current suturing devices. A lot of the ones that were in the past were suction-based and are no longer in use. So the one device that we have... So the one device that we have a lot of is the overstitch device, which is what I'll be talking about. But when we talk about suturing within the GI tract and the endoscopic sleeve gastroplasty, it's important to see where the history is coming from. And laparoscopic plication used to be popular in the States, very popular in Europe and in some places in South America. And when you look at the data for this, it's pretty impressive. So you have anterior plication and greater curvature plication, which sort of reduces the volume of the stomach. And when you look at the data behind that, at the 12-month mark, you have at least a 23% excess weight loss with anterior plication, and in greater curvature plications, about 53%. So it's obviously not as good as surgery, as a surgical sleeve. And people thought that it would be the next thing, but I think the rate of complications were so high that people sort of abandoned it. When you look at the endoscopic sleeve, and this device is no longer in use, Fogel from Venezuela published on this back in 2008 using a series of plication to compare it similar to a VBG. And what's interesting about this is that when you look at the 12-month mark, they had an excess weight loss of 58%, which everyone thought was too good to be true. And what's more interesting, when you look at the BMI of less than 35, the excess weight loss was 85%. So a lot of people thought this is interesting, this could be the next thing. It was replicated in the States with the EndoCinch device, which again is no longer in use, by Thompson and the Cleveland Clinic. And what they did with 18 patients, they tried to copy it with a series of vertical stitches. And even though the results were statistically significant when they scoped patients at 2 months out or even a year out, the stomach looked essentially normal. And this is because the sutures were not full thickness, they were mucosal. So the endoscopic suturing devices that are available worldwide is the POSE, Endomina, and Overstitch. So POSE and Overstitch are FDA approved here for tissue apposition. Endomina is approved in Europe. So when we look at the evolution of the technique, and this was a study published now 2 years ago, but I like it because it gives the history sort of from A to D, looking at the vertical banded gastroplasty, similar technique, to trying to use a series of interrupted triangular sutures, to doing 2 sets of sutures, to doing the technique that we use now, which is a series of continuous sutures as a first layer and then a reinforcement layer. And in this study, which was retrospective, multi-center, they had a weight loss at 12 months of about 17% total body weight loss. The Overstitch device, which is what you can see here, is mounted onto a double-channel Olympus endoscope. The company now has a single-channel device that's been approved. And the way you do the endoscopic sleeve is a series of plications starting from the incisura, going all the way up to the GE junction. You use a helical retractor here called a helix, and it's basically tissue corkscrews. And it's one of the most important parts of the procedure, and that's because it ensures that you get full thickness plications. The suture you use here is a 2-0 non-absorbable suture. The procedure takes around 45 minutes. It's a day procedure, so patients go home the same day. You don't close the fundus, so it's different than a surgical sleeve. And what you see here is what ends up looking like a tubular structure with maybe a little bit of a fundus left over. So the data behind this, or what's published so far, this was a retrospective case series of our center at Cornell, with Spain and the Mayo Clinic being the highest 3 users. With 248 patients, we showed a 6-month weight loss of 15%, and at 2 years, it was 18%. What's more interesting than this is that when you look at the total body weight loss of the percentage of people that had 10% or more, it was 84%, and 15% or more, it was 56%. And why that's important is because when you hit 10% or more, that's sort of the PIVI guidelines of where you get improvement in comorbidities. So for endoscopic procedures, that's kind of what you want to hit. We looked at the 3 different centers, and there was no difference in weight loss between all 3 groups, even though the groups have slightly different follow-ups, slightly different suturing techniques, but New York did slightly better. And then when you look at multivariable linear regression to see what predicted getting 10% or more at the 2-year mark, and essentially it was getting 10% or more at the 6 months mark, which kind of makes sense. So if you are a responder to that technique or a responder to this procedure, then you're more likely to respond later on or continue to respond. Sort of this is our data, and what you can see here, even at 2 years post, the weight loss is still durable. So what's been published outside of sort of the 3 highest centers, and there have been 2 publications that are notable, and we'll mention them. And basically, this was, again, a retrospective series of 3 other centers, Australia, Hopkins, and Texas, Eric Wilson's group. And what they showed that, again, they had smaller numbers, but they had similar weight loss. So 14, 15%, and 18% at the 6-month mark, and at the 1-year mark, they only had the 6-month mark. And so what the conclusions was for this is that for users that are native, then this is this is reproducible and generalizable, so everyone can learn this. Then comes data out of Saudi Arabia with a 1,000 case series at a solo center. So this, like a lot of people were surprised by that and very impressed by these numbers. And what you can see here is they have similar weight loss. So at the 12-month and 18-month, you get 15% total body weight loss and 14% total body weight loss. But also you have improvement in some comorbidities, such as type 2 diabetes, dyslipidemia, and hypertension. So in terms of adverse events, I tried to combine them all together. You do get nausea and pain. So the way you treat this is by really very good patient preparation. So they have immense scopolamine patch the day before the procedure, the day of the procedure. They go home on a series of anti-nausea medications and anti-pain medications. So these are very mild. In terms of severe adverse events, so this is from our case series, with the 248 patients. 2 patients had fluid collections in the left upper quadrant that were treated with IR drainage. 1 patient had a PE, and 1 patient had a pneumoperitoneum and pneumothorax. This was thought to be due to the use of air rather than CO2, and because people don't do that anymore, hopefully this shouldn't really happen. From the Hopkins, Texas, Australia group, they had also 2 severe bleeds that responded with transfusions. They didn't need any endoscopic treatment. And then they also had a serious fluid collections. And then from the Saudi group, again, a high number of nausea and abdominal pain, fluid collection, and then post-procedural bleeding. He had some ESG reversals, or I'm not entirely sure, it's not described in the paper how they did that. So adverse events that are not published, and these are anecdotal, not anecdotal, just from what we've heard outside. So when you're learning how to do the overstitch device, especially passing a double channel that has the overstitch mounted onto it, it takes a little bit of a learning curve. So initially people do it over an overtube, so there's a learning curve with the overtube. So several people have reported overtube injuries unrelated to the device itself. Splenic abscesses, more than what's been published, and this is probably due to people being aggressive in the fundus area. When you think about it, it's only 2 to 3 millimeters in size, the thickness of the stomach, and so if you're doing full thickness plications, people are not being very careful with their diet, you can get that. Gallbladder perforations, I've heard of a couple of cases of these, and these are probably due to the helix going where it shouldn't go beyond the stomach, and so that's just something to bear in mind. And then some people have published on significant bleeds. So we looked at also improvement in comorbidities as a function of ESG. So it's not just important to lose weight, does it have improvement in comorbidities? And what we've shown when we looked at our first 91 patients, that you do get improvement in A1C in diabetics and in pre-diabetics. You do get improvement in waist circumference as a surrogate for metabolic syndrome, and then you do get improvement in blood pressure, improvement in triglycerides, and ALT as a surrogate, again, for NASH. And then what about the learning curve? So we looked at this, and this was published twice. So the Hopkins group published on this, and they looked at their cases, and they required more than 9 cases. You can get to the procedure in under 2 hours. We looked at our case series, and basically, first one took about 5.5 hours. I did it. I was probably one of the early users. No one knew what we were doing. And it took a while, but 35 cases, you can get it under 45 minutes. So how does the procedure work? Cheaply, we measure the distance from the GE junction to the pylorus, and what you can see is a 15 to 20 centimeter shortening of the stomach. And this is because as you're imbricating the stomach, you're making it smaller lengthwise and widthwise, and so there's less volume and less mobility of the stomach. Mayo looked at this also doing gastric scintigraphy. And so the way the procedure works is it delays gastric emptying. This was only published on 4 patients, so we postulate this is the way it works for everyone. But if you look here at a gastric scintigraphy, pre-endoscopic sleeve, only about 16% is retained in the stomach. Post-endoscopic sleeve, the majority of the food is in the fundus. And again, we don't close the fundus, so everything stays there longer. You feel full, you eat less. What about durability? So you do see, when you do these full thickness, you do see full thickness plications, and because of that, you get a little bit of bridging fibrosis. These are one of my earlier ones, so the ones that I've missed where there's no suturing, you can see bridging fibrosis, normal stomach, bridging fibrosis. And really the stomach at 1 or 2 years doesn't distend as normally it would. It's definitely more fibrosis. And we've published on this where we've tried to resuture an endoscopic sleeve, and you definitely can do that, but it's just a little bit harder the second time around. So how does endoscopy compare to surgery? And we did this in collaboration with our bariatric surgeons, presented at the SSAT plenary a few years ago now. So we looked at this with the laparoscopic sleeve, endoscopic sleeve, and the lap band. And obviously this wasn't matched. But when you look at the total body weight loss of the 3 groups, everyone was statistically significant, but the surgical sleeve did much better. So at 1 year, you had 30% total body weight loss versus 18% in the endoscopic sleeve group and 14% in the lap band. So we did better than the lap band, less good than the surgical sleeve. But what's more important than that, when you look at the BMI greater than 40, the results still stand. So the lap sleeve gastrectomy still does better. But in the low BMI group, there was no statistical difference between the groups, sort of suggesting that in the low BMI, 30 to 40, endoscopic options should be done. And in terms of length of stay, everyone goes home the same day compared to the surgical groups, and adverse events obviously are much less. So what about combination? We do add medications. It's a comprehensive weight loss program. They don't just get one shot and done. You treat it as a chronic disease. And we do retighten. So we assess people at the 1-year mark, get a repeat upper GI, and compare it to the one that they had immediately post-op. Obviously, as I said, it's much harder, and they get an additional 10%, not more than that. Obviously, we work with our endocrinologist, so a lot of people are already on medications pre-procedure, and this is someone who's had multiple medications, and then post-endoscopic sleeve, you get a combination of greater weight loss. So obviously it's important, and speaking to a lot of surgeons in the room, you already do a multidisciplinary program. Coming from a GI world, it was new to me. But we do add medications. You can convert to another endobariatric procedure. Remember, you can't do a balloon because you've altered the stomach, but you can convert to surgery. We've definitely had a few patients who've gone on to have surgery. It's a little bit of a longer procedure, but it's definitely doable. And ensure compliance with nutrition, and ensure that patients have a tool concept for weight loss. And so this was published from Lopez Nava in Spain, and what's interesting with these endoscopic procedures is that the better compliance you have, the better follow-ups you have, the better the weight loss is, which kind of makes sense. And so with all these endoscopic procedures, this should be out there. What about cost effectiveness? So we looked at this, comparing it to lifestyle, the balloon, and the surgical gastrectomy. And basically, the most cost-effective procedure, if you have diabetes, is the surgical sleeve. But if you don't have diabetes and your BMI is less than 40, then the endoscopic sleeve is a good option for you. So lesson learned, endoscopic suturing devices, including the endoscopic sleeve gastroplasty, is safe and effective at inducing weight loss in moderately obese patients. ESG is associated with sustained weight loss at the 18 and 24-month mark. Predictors of weight loss is getting at least 10% at the 6-month mark. It could improve comorbidities, and suturing pattern is not as important as getting full thickness. Learning curve depends on prior experience, but at least 35 patients to get up to get the procedure performed in under an hour. And ESG is the most cost-effective therapy compared to lifestyle in the balloon and the sleeve. So the last part of my question, can everyone do it? Probably. But, and what you can see here was with what the previous speaker said, overstitch, all the users are going up, and this was mid-2018. It'll be interesting to see what the 2018 numbers and 2019 numbers, but there's more interest in endoscopic procedures. But we do need randomized therapies, and we're getting there with the endoscopic sleeve. Combination therapy is important, and with trading comes responsibility. So should everyone do it? Probably not. You really need to be part of a multidisciplinary program. Thank you.